The next speaker is Dr. Prashant Pawar, sir. Sir is a consultant head and neck oncologist from Mumbai. We welcome you, sir.
Good afternoon, everybody, and I would like to first thank the organizers for giving me this opportunity. So the topic of my presentation today is management of retrosternal goiter, and we will just have a brief introduction followed by evaluation, surgical approaches, and then I'll provide you a brief summary. Conceptually, we know that retrosternal goiter is any extension of thyroid either below the sternal notch or the thoracic inlet, and there have been many definitions given by various authors if you look into the literature. And there's a beautiful classification given by Randolph, which I'll come to later. But first, the retrosternal goiters are divided into primary and secondary types. Primary is the ones that develop from ectopic thyroid tissue in the mediastinum, and they are no way connected to the cervical thyroid. These are indeed rare, less than 1%. Most common what we see is the secondary retrosternal goiters, which are because of descent of the enlarged goiter in the neck into the mediastinum following the pathway of least resistance. Clinical features, we know that they are very common, multinodal goiters. More common presentation is the elderly patients, 5th and 6th decade, more common in women. One third of them will be barely palpable, and incidentally noted, many patients will be asymptomatic, but majority of those who have symptoms will have compression symptoms, and very rarely 5% cases they may present to emergency because of airway compromise. Over 90% of this will be managed by cervical approach, and in less than 10% cases we'll need an extra cervical approach. The clinical features or the presenting symptoms will depend upon which structure is being compressed, and accordingly trachea compression will present as either dyspnea, stridor, wheezing. Long-term tracheal compression can lead to tracheomalacia, which we should keep in mind because when we do surgery, we can have a sudden airway collapse. Esophageal compression will cause dysphagia to solids initially, followed by that for liquids, and recurrent nerve pressure will cause your hoarseness of voice. So this is the classification given by Randolph and all. Type 1 is extension to the anterior mediastinum. Type 2 is extension to the posterior mediastinum. Type 2 is again divided into type 2A and 2B. 2A is ipsilateral extension and 2B is contralateral extension. 2B further divided into B1 and B2. B1 is extension posterior to both trachea and esophagus, and B2 is extension between the trachea and esophagus. And type 3 is where you have isolated mediastinal goiters. So 85% of these are type 1 going to the anterior mediastinum, and majority of these will be managed by a cervical approach, and very rarely only when you have a retrosternal extent which is wider than the thoracic inlet will you require a extra cervical approach, whereas the posterior or type 2 ones, this is where we need to be aware that we may require a extra cervical approach, and we should have a CVTS backup. Again, primary could be again primary substernal goiter, again anterior or posterior. Again, just a diagrammatic representation of the types we just discussed. And you could also come across mixed ones where you have a primary multinodal goiter enlarged going into the retrosternal region, as well as coincidental primary goiter there as well. So clinical signs we all know of. The imaging, the most important imaging, which is a cornerstone of diagnosis, classification, and deciding the approach, is your CT scan. And of course, you can use MRI as an adjunct for vascular involvement, barium swallow to look at any esophageal involvement. X-ray at times very nicely gives you anticipation of a difficult or a deviated airway. And pre-operative evaluation, apart from your routine investigation that we do, important is your fiber optic laryngoscopy and bronchoscopy. This will help you give dynamic assessment of the airway. Any airway distortions can be anticipated, and you have to document the vocal cord status as well. Again, a nice X-ray showing you deviation of the trachea and a retrosternal extension as well. This is a CT scan showing you type 1 anterior mediastinal extension of an enlarged goiter. This is posterior mediastinal behind the trachea, behind the esophagus. And this is a barium swallow showing you both deviation into the cervical and mediastinal segments of the esophagus. And this is the one that I showed how CT can be very useful. Look at this, the left-sided goiter is not only going retrosternal, but also going to the left side and far posterior. So this is one that will require a lateral thoracotomy as well. And position of the CT scan, when you do a CT scan, many times for CT thorax, they will have the arms abducted, which will cause more plunging of the thyroid into the mediastinum. That is where we need to note that taking a CT scan with the arms on the sides of the patient is very important. Imaging features which will help us decide whether you'll require a CVTS backup is extension of goiter below the aortic arch, extension into the posterior mediastinum, a dumbbell-shaped goiter, and a thoracic component which is wider than the thoracic inlet. Challenges that we face during surgery for these lesions is difficult intubation, rectal nerve handling, parathyroid handling, blood loss because of major vessels involvement, long duration of surgery, and high risk of tracheomalacia. You need a very good team when you are going to manage these patients, starting right from a radiologist to a specialist anesthesia team, experienced head and neck surgeons, and a dedicated CVTS team. Pre-operative preparation now. A good anesthetist team is very important. You need to have your difficult airway cart ready. Awake fiber optic intubation is the safest option. Remember to use your IONM whenever it is available. This is very useful. Apart from that, if you have parathyroid autofluence imaging, we have seen presentations yesterday. Of course, even if you don't have those, at least a good loops, a good headlight, and a good bipolar. Approaches we know are transcervical and extracervical approaches. This is just to give a risk assessment of which patients are going to need a extracervical approach. So low risk are the patients who have a retrosternal goiter with no extension to or beyond the aortic arch, and the mediastinal component either is equal to or lesser than the cervical component, and there's no history of previous surgery. A moderate risk for this approach will be patients who have significant mediastinal involvement up to the aortic arch, but no extension into the posterior mediastinum, and the mediastinal component again is either equal or smaller than the cervical. So this is the patient where you will need a backup, at least that much awareness you should have. And high risk is when you have extension beyond the aortic arch or beyond the carina, and when it is multiple mediastinal compartment involvement in the posterior mediastinum, extension to the posterior pleura, and when you have primary mediastinal goiters or a primary mediastinal malignancies. These are the cases where you will need a extracervical approach, and you must have a CVTS team involved. Now, just tips and some tips during the surgery. A cervical incision, generous low collar incision, is 90% of the cases going to be adequate for your surgery. Routinely, what we do is subplatinal flap elevation, strap muscles. I prefer to divide because space and adequate view is very important. Your superior pole need to be handled the first and foremost. This will help you reduce the bleeding. Identify your external branch of supralaryngeal nerve, and another thing is that when you are dealing with large thyroids especially, start above, then go laterally, and then do your subcapsular dissection. Get a good control on your IJV and your CCA. And superior approach to the rectal nerve has been described very well by Randolph, and this is when you assess the superior pole first, take control there, and then you approach, push the thyroid gland laterally and forwards, identify and dissect the retrolaryngel nerve beforehand, so that when you actually push the thyroid in from the retrosternal component to the neck, there's going to be minimal traction injury onto the nerve. Now, just a few slides about cervicothoracic approach. A T-shaped incision is used. Thyroid dissection is similar to what we have already discussed. Superior pole dissection, standard mobilization. Superior to inferior is the dissection direction, and identify the nerve early. Then mediastinal dissection will identify the mediastinal structures, get good control on the innominate vessels, pericardium, pleura, and phrenic nerve. Then the thoracic inlet dissection, dissection of the nerve in a systematic way. Occasionally, you should anticipate a riding nerve, whereas when you have a tubercle of Zucco-Candle which is encasing the nerve will be at risk. Parathyroids, superior you'll be able to identify very well, but inferior becomes difficult in these cases. And this is what I told you, a riding nerve is very difficult at times to handle. A lateral thoracotomy will be needed when you have majority portion of the goiter involving the posterior mediastinum, especially encountered more on the right side, and whenever it's reaching the posterior pleura, you will need a lateral thoracotomy. And again, when you're doing a lateral thoracotomy, your identification of the nerve in the neck and then covering it with something to identify when you're doing the lateral thoracotomy is very important. Again, reiterating, when you need a CVTS backup or what are the indications of sternotomy is when you have a primary intrathoracic goiter, extension below the aortic arch or pericardium, posterior mediastinal extension, and malignancy infiltrating the mediastinum. Complications, we all know, airway collapse, we discussed tracheomalacia, bleeding, recurrent laryngeal nerve palsy, hypocalcemia because of handling of the parathyroid vascularity, and thoracic duct injury. Post-surgical care is very important. Monitor for airway compromise, tracheomalacia, check calcium levels, PTH levels, voice assessment for recurrent laryngeal nerve palsy, and ICU care is very important for sternotomy cases. Gentle handling, good exposure, and readiness to conversion to sternotomy is very important in these patients. Okay, take home messages: uncommon but an important surgical entity. CT scan is the cornerstone of planning. Cervical incision works for majority of these patients. Adequate neck extension is very important. Sternotomy will be required in select cases, so have your CVTS backup whenever it's necessary. And multidisciplinary team approach is of course mandatory to get best outcomes. Thank you very much.